with that, let's move along to Dr. Lazarus, who has a very long-term experience with Transosseous and has done a lot of studies clinically on Transosseous techniques and can teach us all a lot about how this works in a resident teaching situation and with complex techniques. So go ahead and take it away there, Dr. Lazarus.
Great. Can you hear and see me?
Yeah, looks good.
Wonderful. Well, first of all, Brett, thanks for inviting me for this webinar. This is really great. You asked me to talk about my experience at a large academic institution, which I am at, but you also asked me to talk about the economics of this type of procedure. And I'm also a shareholder in a large private group. So the economics of this are not just academic for me. And so when I talk about that, it's not just an academic area of interest. I have no disclosures relative to this device. I just like using it. So the four things that Brett asked me to talk about is just a little bit of my experience, some technical pearls. Again, talk about the economics of transosseous and I call anchorless rotator cuff repair. A word on the use of grafts and biologics, and finally cortical augments. So when people talk about reasons to not tunnel, the big thing that comes up is suture management, and the suture management it's too painful to do. I've got a partner who always uses the F word before he mentions tunneling. And actually, the suture management is the advantage of tunneling because it's in our control, and so we're not limited by anchor configuration. What I mean by that is you have more ability to add points of fixation for the same amount of exposed tuberosity. We're not limited by having a 1 centimeter bridge between anchors or the number of sutures within an anchor. You can come up with any configuration you want. That being said, you really need to have a plan in terms of suture sequencing, in terms of management. I make use of colored hemostats and as I'll show you, varying different colors and types of sutures just to keep track of things. So Gary Updegrove, who's one of our former fellows, put this together. It seems really complex, but in fact, this is just a PowerPoint. He did it for himself, but he now shares it with all the fellows. So this is a 3-tunnel repair, and these are the 10 steps that you take by passing these sutures in this configuration. 10 steps later, you have a transosseous double row repair with multiple points of fixation. And again, it seems complex, but once you think of it in sequencing in those terms, it becomes very, very easy. And so hopefully, so I boiled this down to a 1-minute video. So this is a tear that ended up being 4 tunnels. And so then this will be a double row repair. We could talk about, if you want, whether or not you need a double row repair for this transosseous technique. But this is the tensor tunneler. I'll put a passing suture through, and then you can pull anything you want through. And so I use tapes, and I use suture for the medial row. And so again, you can see the 4 tunnels with different tapes, different sutures, and then it simply becomes a rotator cuff repair. And so you pass sutures. This is how I tie the horizontal mattresses, just bringing one limb from 2 consecutive tunnels out and tying them together with a non-sliding knot. You create a medial row and also a rip stitch for the lateral row sutures to bridge across, as I'm showing you here, without having that single point of fixation down to a single anchor. So this is what I just did 2 weeks ago with my PA. And this is 4 tunnels. Again, you get that spread of suture that Brett talked about earlier, so you don't dog ear as much. You get the ripping effect of the tapes going over the horizontal mattress suture, and you get the footprint compression effect of a double row repair. So all the things we really want to do with cuff repair. So several years ago, Eric Black, one of our fellows, did a retrospective study looking at my patients and cost double row anchor versus transosseous. And what you can see here is, as you would expect, I don't know if you can see my cursor, but for the transosseous technique, the cost is the same. The cost remains stable regardless of the size of the tear. But obviously, the larger the tear, the more anchors you use, the cost of the anchors goes up. And so for the large and massive tears, the cost difference becomes substantial. These were my first tunnels relative to already being very experienced with anchors, yet the surgical time was the same. So it is not a procedure that takes longer. Now, Adam Seidel's now at University of Colorado, then did a prospective study with us when he was one of our fellows. And again, the cost differences in this study was even greater. And so for large and massive tears, the cost difference was over $1,000 per case. And that adds up. And based upon simple shoulder tests, the results were the same at 3 months, 6 months, and over a year. So outcomes were the same, cost dramatically less. I don't know if anyone has experience with constructing a bundled payment model, but we have done this. And so we have constructed a bundled payment model for rotator cuff repair. And this is the first step. The first step is looking at cost data per surgeon. And the reason this is important is, number one, insurance carriers are most interested in bundled payments when there's a large variation between cost per surgeon, because they would rather we take the risk than they take the risk when there's that much variability. And number two is, obviously, the more outlier surgeons you have, the more likely you are to break your bundle and lose money on the bundled payment. And so I can't show you the absolute numbers, otherwise my CEO will kill me. But this is me as baseline. This is our hospital. This is, by the way, up till last month. So this is our hospital, our surgical specialty hospital, and these are the 4 busiest cuff surgeons. And what you find, so I'm 0 because I'm the lowest, and then these are the differences above me. And so what's really interesting is me and surgeon B do all the massive tears, do all the grafts, do all the revisions. The insurance carrier could care less, and our hospital administrator and our CEO could care less, because it's all one bundle. And so the surgeon B happens to be a very good surgeon who's very cost effective. He's doing all these graft revisions, and he's just $700 above me. It doesn't matter. They hate him. Surgeon C does only the smallest tears. He only does single anchor tears. They love him. And then surgeon A is not going to be doing rotator cuff repair very long at our hospital if he keeps doing this, because he does not do all the revisions, and he is $1,400 on average above me per case, despite the fact that I'm doing the more difficult ones. So if as we do more revisions, as we do more SCRs, things like that, all these things are included in the bundle. And so you have to try and trim your costs somewhere. And Bob Tadgen years ago published a paper looking at the single best way that you can trim your cost of cuff repair is by lowering the cost of anchors or just not using them. So a word about graft augmentation. I showed this video before, but the reason I like tunneling for graft augmentation is the procedure is no different. The steps are almost identical. Instead of tying the horizontal mattress like that, I actually pass it through the graft and then tie it. And so once you do that, you essentially have the medial side of the graft fixed down with the medial row of your rotator cuff, and then you're just tying the tapes over the top. So it really doesn't add any significant number of steps to what you're already doing, as opposed to when I did these with anchors, it seemed like it was just a completely different procedure than rotator cuff repair. This seems to be the same thing, just adding a graft for reinforcement, for me, primarily for revisions. And then Brett mentioned SCR. SCR is limited by cost. It's an extremely costly procedure. And so if you eliminate your lateral sided anchors, you can really, if we show some effectiveness of this down the line, make it a cost-effective procedure. And so, yes, I use tunnels on the lateral side for all my SCRs as well. So, we hear a lot about the future biologics, biologically active suture. You hear about this all the time. And I always say to myself, well, does it really matter if the suture is attached to an anchor, because the suture is not really exposed to the marrow. We hear about marrow stimulation, either locally or systemically, medically. And again, I always say, well, does it really matter if the marrow access to the undersurface of the rotator cuff is being obstructed by numerous anchors? And so I think that tunneling really lends itself to these future biologic techniques. Brett asked me to mention cortical augments, probably because Grant Garrigus, one of my former fellows, insisted on writing this technique paper years ago. And so this was a device meant for open surgery, which we used for arthroscopic surgery for tunneling. And Brett mentioned these. I've used generic augments. I've used specifically designed augments, polyethylene patches, 2.4 millimeter plates. But once I switched to tapes, I've not, cortical augmentation for me is a once every other year phenomenon. These tapes just tend to not cut through bone. And if you really focus on making the lateral aspect of your tunnel as far distal as possible by abducting the arm before you seat the tunneler, you cortical cut through a rare occurrence at this point. Okay. All this science, best reasons to tunnel, and that's how I'm going to end my talk. So best reason number one, we've all had these patients who want their rotator cuff repair to be the hardest one you've ever done. And so they say, Doc, how many anchors? You say, none. Reason number two, for the patient, we've all had these patients, right? That they're 6 months out from surgery. You know the repair is good, but they're still having pain. You send them for the MRI scan. And because you didn't use anchors, there's so little artifact in the greater tuberosity. The official radiology reading is normal shoulder, right? There's the tunnel. They don't even recognize that this patient's had cuff repair. And then the most important reason is when you have that annoying partner who wants to impress you with their 8-anchor rotator cuff repair and can't stop talking about it, you can say to them, anchors are so 2010. Thank you.
A collagenous fibril attached to the muscle architecture, like the original tendon was. So I tend to be a double row guy, which has been, a full foot, if assuming the tension's okay, reconstitute the entire footprint, the surface area of the double row, reconstruction has been linked with less re-tears. That would be my answer.
Yeah, I would agree with that. But when I teach the residents and fellows, I always say cuff repair is a battle of tension versus coverage. And so if you can gain coverage without excessive tension, I think the literature would suggest, at least for large and massive tears, integrity should be improved down the line. If you can't, then I think a single row, more medialized repair is warranted.
And do you guys ever, you can do a transosseous technique and just not go as deep, right? Like, to me, you're doing the same thing as you're doing a medial row. Like, you're just not taking as much tendon laterally, right? It's achieving the same thing, but you're still laying the tendon down. And I agree with you. It's just a matter of tension. And I understand the idea of a single row, but.
Yeah, when the tension's high, one of the things I do is, like, often you'll have a chronic supra and acute infra. So infra double row, the chronic supra that's under a lot of tension, do a tunnel, and then use arthroscopic Mason-Allen sutures like LaFosse locking loops to essentially do a single row, and then you just tie the knot low and lateral. So it's a single row repair just without an anchor.